All right, so again, this first talk is basically AR resistance mechanisms, and again, we're going to really concentrate on resistance and talk a little bit about how the AR plays a role throughout the whole course of prostate cancer. So these are my disclosures, and I also really want to thank Emmanuel Antonarakis, who's a good friend, who provided me some of these slides as well. So we know that based upon the seminal work that all of us are aware of from Huggins and Hodges, that as prostate cancer is an endocrine disease. So it's interesting when you look at this initial paper, which is 1941, we all remember Huggins and Hodges, but I was digging this up today. There was a PhD at the University of Chicago who was also involved in some of this work throughout the 40s, and it was actually W.W. Scott who then became chair of urology at Hopkins. So, Dr. Scott, even though he wasn't really recognized as part of this, was really integral to this team. So this is a very important slide, and you've seen this many times. This is the canonical pathway, and again, this previous discussion that we just had of how actually testosterone engages the androgen receptor and why it's an endocrine disease. And I think this is very important for all of us to know, to understand, because once you understand this, then we're going to then understand how these drivers, how these resistance mechanisms are going to come into play. So we know that testosterone, for much of it, is actually bound to sex hormone binding globulin. It actually dissociates, it diffuses into the prostate cell. It thus undergoes basically transformation to dihydrotestosterone, which is a much, much more powerful ligand. It then binds to the androgen receptor, which is in the cytoplasm and historically is bound to a chaperone molecule. Once you get binding of the ligand of DHT to the AR, you get nuclear translocation, and then starts the whole process of transcription and ultimately translation. So this is, again, you've heard me say this. If somebody would have told me 10 years ago that this concept, that I would have to understand this, would be critical to the management of prostate cancer, I would have thought that you were crazy. But now I think for those of us that manage prostate cancer along the entire disease spectrum, this is very critical. Now, underneath here is basically the AR is encoded for by the X chromosome, and it has all these, basically these exons and introns. And so it is the N-terminus, which is involved in transcription. It is the C-terminus, which is the ligand binding domain. And then you have a hinge region. So this becomes very important as we talk about resistance mechanisms. So this slide we all know, these are all the various drugs that have been approved in the mCRPC state. And as you know, and what you've heard is that now all these agents are now becoming used more proximal in the disease state. And so what's the significance of that? So we know about the Charter trial. So this is the use of ADT and docetaxel that particularly should be used in high volume metastatic hormone-sensitive patients. Then you have the Latitude trial, which is in the same patients, metastatic hormone-sensitive, and the use of Abiraterone. Then you've heard earlier in the breakfast program about the use of basically these newer AR antagonists. So this is the Prosper trial, which is the use of Xtandi in the M0 space, and then the SPARTAN trial, which Steve and Larry talked about, which is the use of apalutamide in the M0 space. So again, we're getting the utilization of all these drugs more proximal in the disease state. And so we know that what happens is that when you start driving these cells, you start to get these mutations. And this is a slide that I borrowed from Andy Armstrong and the folks at Duke, is that you have AR-dependent mechanisms, and then you also have AR-independent mechanisms. And these are the mechanisms that drive resistance. So these are just some examples of, what are some of these resistance mechanisms. But they still, again, involve for a lot of times, the AR. So you can actually get activation of the glucocorticoid receptor that conveys resistance. You can get production of DHT from a separate ligand that's not testosterone. This was reported out at PCF. This is the work done by the Prostate Cancer Dream Team. A lot of this was done at Michigan. So you get if you have a biallelic CDK12 loss, These patients, again, are heavily treated, but it basically makes these patients more susceptible to immunotherapy. So this is an actionable mutation. This was just published in December. Again, same thing here is that if you have patients that test high in microsatellite instability, this too can render them more responsive to immunotherapy. So all these mechanisms now basically become important because now at least we have drugs that are targetable agents. Many of you know this article. This is published by Robinson and again, in the prostate dream team, where we know that 23% of metastatic CRPC patients harbor DNA repair alterations. This was the work by Pritchard, published in the New England Journal back in 2016, and this has really changed the landscape because we know that about 12% of men dying of prostate cancer with lethal prostate cancer actually have DNA damage repair genes. And what makes this interesting is that it's irrespective of age and family history, which is what we've always talked about, is the importance of family history. The people that were dying of prostate cancer, oftentimes they did not have a positive family history for prostate cancer. So again, this is sort of, as we talk about DNA repair, it's going to become important that we understand the whole concept of DNA repair. How BRCA, how PARP, how they engage. So we know about double-stranded breaks, and so this is the mechanism in terms of how you have to have this dual lethality. You have to have this homozygous deletion of the DNA repair genes, and that's when PARP inhibition becomes effective in cell death. It's this concept of dual synthetic lethality. Many of you know about this trial. This is with the Laparib in basically heavily pretreated patients. Again, and then these trials are just have come out. This is the Triton trial looking at Rucaparib. And again, this was based upon the identification of deleterious somatic or germline alterations. And again, you see a partial response in those patients that test positive. And because of this, Lenny and his team in Philadelphia, I know many of the audience members were here, they came up with a consensus paper of the role of genetic testing for inherited prostate cancer risk. And this is going to become commonplace in many of our practices. Now, what's going to be the problem here is that we may overload our system because there's just not enough genetic counselors. Again, though, but when you go back to this schematic here, it is the understanding at the molecular level of the AR. And there has been a lot of work looking at this ligand binding domain. So we've heard people talk about, Dan was talking about it, Larry, of this concept of AR splice variants. So the most commonly studied right now and the most abundant is this ARV7. So what do we mean by that? So again, this C-terminus, this ligand binding domain, due to treatment pressure selection, actually drops out. So the receptor now cannot bind androgen. So you say, okay, well that should be good, right? Well, the problem is it stays constitutively active. So even though you cannot bind androgen, the receptor still stays active and you have sustained growth. So a lot of this was brought out by Emmanuel Antonarakis. Many of you are familiar with this. And we know that they looked at the prevalence of ARV7. And again, I'm not going to belabor you with this, but baseline prevalence is about 12%. But then the V7 status goes up as you get exposed to more therapies. And if you test positive for ARV7, your PSA 50 is basically zero, whether or not you got Abi or Enza, because again, these drugs are modulating the androgen receptor axis. Now, it's interesting, this is the Hopkins test, and this is based upon CTCs, and they're measuring mRNA. This was the study done by Howard Shear and his group, looking at a different ARV7 testing component, and again, this is when the folks from Genomic Health, or excuse me, Genome DX, Genomic Health, and Epic. And again, it's a CTC-based assay, but they're looking at nuclear proteins, whereas the Hopkins is looking at mRNA. This was a trial that basically was reported out by Andy Armstrong at ASCO. This is the Prophecy trial. It's multi-center. These were sort of the eligibility criteria. It's for people who were candidates for ABI and Enza, and what they wanted to do was look at both tests and see how they performed. The endpoint was the association of baseline ARV7 with radiographic or clinical PFS. Again, so they looked at both the Hopkins assay as well as the EPIC assay, and the bottom line is that there were some clinical parameters that had a low AR prevalence, and the biggest ones were low LDH and a CTC count of less than 5. There was no differences in RPFS or OS between the Enza and ABI groups, and again, the median RPFS and overall survival was 5.8 and 20.3 months. So again, there are two tests, and you just have to know that they're out there. But again, that's not the only thing that people are looking at. There's people looking at ARV7, obviously. I'm going to go through this because I'm running out of time. But they're looking at circulating tumor DNA. They're looking at cell-free DNA. So there's a big need for these predictive and prognostic markers. So the AR continues to be a major driver. We need to understand the nuances of resistance. And as patients continue to progress clinically, there is a crucial need to develop better predictive and prognostic markers. For any of you that have read these books, Harari, who wrote *Sapiens*, knowledge that does not change behavior is useless.